The new valve disease guidelines classify patients with aortic stenosis in one of 4 stages, according to their gradient and symptom status. Patients move through these stages as their disease progresses. Listen to a patient with stage C aortic stenosis and notice the second heart sound. The classic physical findings of calcific aortic stenosis include a delayed carotid upstroke, a harsh, late-peaking systolic murmur, and a soft or absent A2. Listen first to a patient with a preserved A2 and compare that to a patient with a soft A2. First, a preserved A2, and now a soft A2. The murmur of aortic stenosis will sometimes be audible at the apex with an increase in pitch. This GALLAVARDIN phenomenon always occurs in the presence of a calcified aortic valve. On occasion, this apical murmur has been mistaken for mitral regurgitation. However, careful auscultation reveals that the murmur retains its characteristic late-peaking shape at the apex. Listen to this murmur first at the second right intercostal space, and now at the apex. Aortic stenosis results from an active process involving inflammation and lipid accumulation, eventually leading to calcification of the valve leaflets. As the valve calcifies, the excursion of the leaflets decreases and the murmur peaks later in systole. Listen to this later shift in the peaking of the murmur as the disease progresses from mild stenosis to severe. First, a patient with mild aortic stenosis, and now a patient with severe stenosis. Surgical aortic valve replacement is still the treatment of choice for patients with severe symptomatic stenosis who are at low or intermediate surgical risk. Patients with a prohibitive surgical risk should be considered for TAVR by a heart valve team. Listen to a patient with combined aortic stenosis and regurgitation. Transcatheter aortic valve replacement requires imaging the aorta with CT, echo, and contrast angiography for optimal results. The goal of this multi-imaging approach is to accurately measure the aortic annulus, the virtual ring formed by the bottommost extent of the aortic leaflets, as shown here in green. Rather than a cylinder, the aortic root and annulus form a 3-pronged coronet with 3 anchor points, one at the bottom of each aortic cusp. This multi-imaging approach reveals that the aortic annulus is an oval structure with one diameter several millimeters longer than the other. The longer diameter dictates the size of the implanted valve, and hence this measurement is crucial for a successful TAVR implantation. Listen once again to a patient with combined aortic stenosis and regurgitation. Once the precise measurement of the annulus is confirmed, the correct size valve is positioned in the aortic arch inside a catheter. The catheter is then advanced to the aortic root, and the valve is deployed using a balloon inflation. After the valve is successfully implanted, the catheter is withdrawn, and echo imaging is used to assess any valvular or paravalvular leaks. The implanted TAVR valve sounds like other bioprosthetic aortic valves, with a soft systolic murmur and a normal closing sound. Listen to a patient with an implanted TAVR valve. In summary, aortic stenosis results from an active process involving inflammation and lipid deposition, leading to calcification. Surgical valve replacement remains the treatment of choice for patients with low to intermediate risk. Those with a prohibitive risk should be considered for TAVR by a heart valve team. A precise measurement of the aortic annulus is essential for a satisfactory valve implantation. Listen once again to a patient with combined aortic stenosis and regurgitation.